Good morning, everyone. I'm going to be talking about managing posterior polar cataracts. PPCs are known to be associated with an abnormal addition of the posterior capsule to the polar opacity, or there is a pre-existing weakness to the posterior capsule, both of which predispose the eye to PCR during cataract surgery. And so for this reason, they are challenging even for skilled cataract surgeons. Identification of the posterior polar cataract on slit lamp examination, dilated slit lamp examination, is the first step in successfully managing this type of a cataract. The cataract has a characteristic bullseye or onion peel appearance in the central part of the posterior capsule. So prior to surgery, a thorough anterior and posterior segment evaluation, particularly evaluating the integrity of the posterior capsule, is essential. Associated types of cataracts such as nuclear sclerosis or cortical cataract should be noted. If there is a total white cataract in one eye, the fellow eye can give the surgeon a clue about what has gone on in the eye. For example, the presence of an ACIOL or another polar opacity in the fellow eye. So the surgeon knows to anticipate problems and start following the protocols of PPC in that case. A pre-op AIOS2025 will also give an idea about the presence of PC dehiscence. Coming to pre-op counseling, it's important that the patient and their caregivers are counseled carefully regarding increased surgical time, possibility of a PCR or nucleus drop, and of a retinal intervention in secondary IOL implantation. These cataracts can be associated with the posterior capsular plaque, so necessitating ND-YAG caps post-procedure should be explained to the patient. We can aim for a capsular rhexis of size 5 to 5.5 mm. The rhexis should also not be too small, as this can lead to increased hydrostatic pressure during hydrodelineation and cause a posterior capsule rupture. On the other hand, if the opening is too large, it may not provide adequate support for a sulcus fixated IOL in case the posterior capsule is compromised. Nowadays, with femtosecond lasers, it is possible to create a customized CCC. So hydrodissection should be avoided as it may cause hydraulic rupture of the posterior capsule and leading to a nucleus drop. Only hydrodelineation should be considered because it creates a cushion of epinucleus and an endonucleus which is easily fakeable. So it is performed by depressing the tip of the hydrocannula into the substance of the fluid, substance of the lens given, and multiple injections of fluid are given in a controlled manner to hydrodelineate the nucleus, and we can see the characteristic golden ring sign which is obtained. Avoid nucleus rotation as it could add more stress on the already weak capsular bag, leading to a PCR. So technique of nucleus management depends on the grade of cataract. For soft cataracts, adjacent trenches are created in the nucleus to create a bowl, which is then emulsified within the cushion of the epinucleus, which is seen here. For harder cataracts, step-by-step chop in situ and a lateral separation technique can be used. Ideally, we want to do a slow motion phacoemulsification with low aspiration, low infusion, low vacuum parameters. The low vacuum and aspiration rate maintain a stable anterior chamber, and the low infusion drives less fluid around the lens. Inject viscoelastic from the side port whenever the phaco or irrigation aspiration probe is withdrawn from the eye. This helps to keep the anterior chamber well formed and prevents forward bulging of the posterior capsule throughout the surgery. Any major fluctuations in the anterior chamber should be avoided. Coming to epinucleus management, it should be stripped 360 degrees from the capsular fornicis before approaching the centrally attached plaque area to avoid loss of epinuclear or cortical matter into the vitreous. The central plaque is left intact until the end. It is then slowly stripped and aspirated in a controlled manner. The cortical matter is removed in a similar fashion. In the unfortunate event of a PCR, dispersive viscoelastic should first be injected from the side port to coat the rent before withdrawing the phaco probe from the eye. This helps in tamponading the vitreous and preventing its entry into the anterior chamber, and it also avoids enlarging the area of PCR. You can see the PC rent in this patient. So after the PC rent was discovered, bimanual anterior vitrectomy was done, cortical matter removed, and it was made sure that there were no vitreous remnants in the anterior chamber before implanting the IOL. Postoperatively, the patient is doing well with a BCVA of 6.6. So in bimanual irrigation aspiration, it is usually preferred. The infusion bottle should be lowered, and with or without triamcinolone should be done with low suction and high cutting rate. This helps to remove the vitreous completely from the anterior chamber. The bimanual irrigation aspiration, it optimizes better control and ensures anterior chamber maintenance, and aids in the complete removal of the cortex. So this video again shows similar use of a bimanual INA and vitrectomy along with triamcinolone after a PC rent, and a 3-piece IOL was implanted after the vitreous was completely cleared from the eye. PC polishing can be avoided due to fragile nature of the PC, and we can consider ND YAG caps in some patients. Coming to IOL implantation, the intraocular lens in an eye without PC rent is carefully injected, taking care to avoid the posterior capsule during implantation. But if there is a PC rent, so IOL implantation can depend on the size of the rent. If the rent is small, it can be converted into posterior capsular excess, and a foldable IOL can be implanted into the bag. But in the case of a large rent, we can use a sulcus supported 3-piece IOL, and the lens can be optic captured to stabilize the IOL. Other options can be a glued IOL or a scleral fixated IOL. So what is the use of femto in PPC? Advantage of femto in PPC is that the nucleus is already divided and very little manipulation is required. Preset laser energy in flax usually depends on the amount of nucleus sclerosis. Normally we keep it around 500 micron from the posterior capsule, but in case of a PPC, we can keep it around 800 to 1000 micron from the posterior capsule based on the OCT. This is to prevent any inadvertent damage to the posterior capsule. Femto delineation, which is done here, it has an advantage over the conventional hydro delineation that we do, because it creates multiple and precise layers within the nucleus, and thereby it prevents the need for any hydro procedures. So to conclude, avoid hydrodissection, avoid any rapid buildup of hydraulic pressure in the capsular bag, mechanically cushion the polar opacity during surgery with the help of a visco, low flow parameters like low aspiration and flow parameters for phaco, prevent sudden shallowing of the anterior chamber and forward bulge of the capsule, and always anticipate a PCR. So by following these tips meticulously, excellent outcomes can be obtained in patients with posterior polar cataract. Thank you.